So I'll be just talking about my experience with fibrin glue to close retinal breaks successfully in complex retinal detachments with silicone oil in situ. So fibrin glue has been used in ocular surgery for corneal purposes, and it has also been used in simple retinal detachments where it was used to obviate the need for tamponade. It was used to close the breaks, and then oil and gas was not required. However, it has not been reported for complex retinal detachments where oil is retained. So we had this patient who had a failed retinal detachment surgery for complex PDR. Oil was already in the eye. So we thought we have nothing to lose anyway, she will be losing her vision. There was an open break which was causing this. So after little bit membrane peeling, we put fibrin glue to close the break, and there was an immediate retinal reattachment with minimum positioning. So encouraged by this, then even a long-term follow-up, she's doing well. The retina is attached, there is no inflammation, intraocular pressure is normal, and the glue is not visualized within few days after surgery. So encouraged by this, then we in complex PDR, we started using it where we could not do laser to close the breaks. So as membrane peeling proceeds, it's common to have iatrogenic retinal breaks which get covered by blood. Attempts to remove this pre-retinal blood were unsuccessful. So after fluid air exchange and drying the retinal surface, these two retinal breaks were treated with the two components of fibrin glue which are injected sequentially. First, the blue top thrombin is injected, which is less viscous, and then you see these clots. These disappear by the third post-op week and the retina is attached and the glue is not visualized. Similarly, a second case, again bleeding during surgery, which is not allowing laser for the breaks. So the two components of the glue, fibrin and fibrinogen and thrombin, are injected sequentially, one after the other. Preferably the more viscous one should be injected first, but either can be injected first with good results. So this is again a third case. Here the break was very close to the macular center, so laser was avoided, and we injected the two components of the glue. There was inadvertent excess injection, but that does not matter. Post-operatively, you see the first day the break is closed, and by 6th day the retina is attached, glue is gone. So then we started extending the indications, and this is a most of the macular hole RDs we can do an ILM peeling and the retina detachment can settle down, but sometimes we are not able to do an ILM peel. So this was a resurgery for a macular hole RD, and we injected fibrin over the macular hole. So the both are closed and attached. Similarly, old RD with a macular hole. So the hole is closed and retina is attached, and within 6 days the glue is gone. Another patient, here the hole did not completely close, but at least the retina got attached. What we saw in this patient in the first post-op period, through the macular hole there is subretinal glue, as you can see the track. And within 10 days we can see that track has become atrophic, subretinal atrophy. So this is a word of caution that when we are injecting it for macular holes, probably it will cause atrophy around the hole and affect the vision finally. So this is the first time we could document atrophy at the site of subretinal glue. So it's good for peripheral breaks at least, but probably not for breaks close to the macula. So it can be a useful adjunct in the management of complex RD, especially when laser is not possible for breaks due to bleeding, edema, or proximity to macular center. Glue is not seen very early in the course, there is no adverse effect with silicone oil, and need for post-op positioning is significantly reduced because the break is already closed. Instead of waiting for the laser effect to come, which takes 3 weeks. So before that itself the break is closed immediately. So tamponade effect is not required. So positioning is not required. Thank you.
Ma'am, in the first case that you mentioned, you put glue under oil, madam. The first case.
Yes, oil was already in.
Okay, you can put the glue under the oil also.
Yes, I did it in that case. Okay. Though ideally the surface is supposed to be dry. But in that case we put it with the oil already there.
Okay. And what if there is a retinal hemorrhage over the break? Can we put over the retinal hemorrhage, but doesn't work probably?
No, you can. I think you can. Because the break, the blood will go away and then this will still be there.
This will stay.
What about the inflammatory component? I used Inofi and tried doing peri-macular surgery. I tried to put the glue, but it not work. But I had a severe.
Can we have the other mic on, please?
Yeah, mic on, please.
Any case of intraocular inflammation following
No, not at all, not even one.
I used for one failed macular hole case. I tried doing that, but I had a very severe post-operative hyperpion and all that. Maybe I used gas. Maybe the entire
No,
thing came
see,
into that
patient
chamber.
patient might have allergy or hypersensitivity to it. It's a biological material which is not in itself. It is not toxic to the eye. It is not toxic to the eye, but the patient may have individual patient may have allergy to it. So that may be the reason you had this.
The
I
immediate
have not
post-op
had
day
it.
I had, but within 3 days everything got cleared with the topical steroids. But somehow I was very scared to use it again and so often.
I've used it in many cases, no problems.
Not even had no reactions the next
No.
post-op day. Absolutely.
Sometimes if you excess injection is given, it may go and collect as in the anterior chamber. But that's
Because
a
the
glue.
control is so difficult under air, the one drop you have to put
Yeah,
in,
yeah.
that is not easy to happen.
Yes.
Sometimes it slips. So much of fluid goes inside. Once it goes inside, once it forms a
You
clot,
can't take out, yeah.
you cannot take it
can't
out.
take it
No,
It's all
so
stuck.
what Dr. Mudit is doing is he's using his viscous fluid injector. So that is a controlled injection. It's a particular pressure at which it goes. It's automated. So it goes drop, and he can stop with his foot switch. So that's one. I use a 2 cc syringe because that gives more control than a 1 cc syringe. And
He uses a 2 cc syringe and not a 1 cc syringe.
not one, because one is longer. The tuberculin syringes are longer, so control is less. 2 cc is smaller. I've not had a problem of lack of control. You just try it out
Even
outside.
that one drop makes a large clot,
Not really. You might have
It's
injected
like-
more thinking that it is one drop.
maybe.
You saw those cases. It's not
Yeah.
like that. But possibly what happens is it gets blocked outside after some time. So now if you have not first expressed it outside, you are going in with a blocked needle, and then you might put excessive pressure, which causes an sudden. Yeah. So before you go into the eye, each component you have to inject out. Eject some outside, so that the needle is not blocked when you are in.
Ma'am, how much into the periphery have you tried?
I mean, I did not have to go much peripheral because most of these were PDRs.
Okay.
But as peripheral as you can see, you can go. And the safety is more. The more peripheral you are, the more the safety, because the macular toxicity and whatever. But I showed one case where we saw subretinal atrophy. So I think
Yeah, that's
macular
in the
holes we have
macular
to be
hole.
very careful. We may not get the vision. A hole may close, but vision may not be there.
Thank you, ma'am.
Thank you. Thank you.